Today we are going to discuss about congenital tubulopathies, and first of all we will going to look at Gitelman syndrome. These are tubular defects, but these all syndromes like Bartter syndrome, Liddle syndrome, Gitelman syndrome are congenital of type. Okay, so first of all we can see that Gitelman syndrome is autosomal recessive. It is passed down on the generations by autosomal recessive inheritance. Okay, and what exactly is Gitelman syndrome? It's the defect of sodium chloride co-transporter of distal convoluted tubule. Okay, it is the defect of sodium chloride co-transporter of the distal convoluted tubule, and it's worth mentioning that it is not to be confused with the Bartter syndrome or Fanconi syndrome. So here the word distal convoluted tubule is very important. And the other transporter that is being affected is known as TRPM6. And what is this? TRPM6 is the transporter for the magnesium reabsorption. So it means that in the distal convoluted tubule, sodium chloride and the magnesium is being reabsorbed. But if the defect is in these channels, TRPM6 and the sodium chloride co-transporter, can these ions be reabsorbed? No, they will pass down into the urine. Okay, and the hallmark for the Gitelman syndrome is salt wasting, that is NaCl, and polyuria, because these all ions are hyperosmotic. It means they have the uh, ability to attract water. Okay, so due to the attractance of the water, and water is also being lost into the urine, so we can say that hallmark for the Gitelman syndrome is salt wasting. Salt is being wasted, salt wasting, and the second is the polyuria, because water is also being lost. That's very logical, right? So let's talk about the features of the Gitelman syndrome. What are the features, the important things you need to remember? For example, if a child come to you with parents and the parents indicate that the child is not gaining weight, because 60% of our body consists of water, right? So if the water is being lost, how the child is gonna gain weight? So if a one month old children or baby is coming to you with parents and the parents are complaining that my child or my baby is not gaining weight, so you can say that the first feature is failure to thrive. Failure to thrive means that it means that the weight is not being gained in case of babies less than 1 year old. Okay, and when there is polyuria, you can say that water is being lost. Second feature is that there is dehydration in the body. Okay, there is a lot of dehydration in the body. You can say that there is dry oral mucosa, or you can say that there is sunken anterior frontanels. Let me write here. There is sunken anterior frontanels in the children, sunken anterior frontanel, and the second is the dry oral mucosa, because the water is being uh, passed into the urine, dry oral mucosa. So yeah, that's the kind of dehydration. So doctor may think that it's the case of loose motions, but it's not the case. You should ask the parents that is the child having loose motions. So if the mother asks no, she or he doesn't have loose motion, so you must think of congenital tubulopathies, that it's the passing of water along with the salts into the urine. So you should eradicate, or you should rule out the case of loose motions here. Okay, loose motions has been eradicated. So the next thing is that the diaper change frequency has been increased. Okay, because the child is urinating a lot, so diaper change frequency diaper change frequency is increased in this condition, right? So it's logical that if a child is urinating a lot with salts and like sodium chloride and magnesium, diaper change frequency automatically increase. The next thing is that due to the water loss, right? Due to the water loss, our body respond to that dehydration, and first of all, the renal perfusion is less, right? Because the blood volume in the child or in the adult or in any person is low. So renal perfusion in this condition is low. Renal perfusion is low. It means that GFR is also low. Glomerular filtration rate is low, and this low GFR will trigger the system known as renin-angiotensin-aldosterone system is being activated, and due to this system, aldosterone will be produced, right? Aldosterone will be produced, and this aldosterone will act on the epithelial sodium channels. Let me draw it. This is the lumen of the nephron, more specifically the collecting tubules, right? And here is the epithelial sodium channel. Aldosterone will cause water and salt reabsorption. Water and salt reabsorption, but there is a price we have to pay for this, right? So there is subsequent potassium and proton or hydrogen lost. It means that when aldosterone is compensating the dehydration process, there will be water and salt retention due to there is dehydration in the body, but subsequently the system works in a way that it also loses the potassium and hydrogen. So what is the other name for proton losing? We can say that the person or the patient or the baby will suffer from alkalosis because acid is being lost and potassium is also being lost. So we can say that there is hypokalemic alkalosis, and it's due to the kidney, so we can say hypokalemic metabolic alkalosis, right? So the person suffering from Gitelman syndrome or the baby suffering from Gitelman syndrome will must have hypokalemic metabolic alkalosis, and it's logical due to the loss of protons and the potassium. Aldosterone in the serum will be high because aldosterone is a compensatory mechanism, right? So these all defects like Gitelman syndrome, Bartter syndrome, Fanconi syndrome, these all result in serum aldosterone increasing, right? So we can say that these diseases are causing secondary hyperaldosteronism because it's not primarily, it's secondary hyperaldosteronism. And this increase in the aldosterone is not primarily, it is just like compensatory mechanism due to dehydration because of the RAS system that is being activated, right? So, and the other thing we need to see in the child is the sluggish Moro reflex. Moro reflex is a very important reflex in the babies or newborns, and we can see that there is sluggish Moro reflex and there will be poor cry. The tears consist of water, right? So the water is less in the body, so there will be poor cry, and it can be a manifestation of hypokalemia because the potassium is already being lost into the urine due to the effect of aldosterone. Next thing is that one of the most important thing you need to remember that due to magnesium loss because TRPM6 channel is also defected, right? TRPM6 channel that is responsible for magnesium reabsorption is also being defected. So there will be magnesium lost. And magnesium indirectly releases the parathyroid hormone. Parathyroid hormone. If magnesium is not there, so release of the parathyroid hormone is decreased. The parathyroid hormone in the circulation will be decreased. It will result in low calcium because parathyroid hormone is responsible for calcium reabsorption, right? So calcium will be low in the body. We can say that the Gitelman syndrome results in hypocalcemia. hypocalcemia, and it's logical due to the decrease in the magnesium levels. And one of the most important features of hypocalcemia is the tetany, right? There will be a tetany manifestations, and tetany can be in two forms. We can say carpopedal spasm, the finger and the thumbs, there will be a spasm of those muscles. So we can see carpopedal spasm in case of hypocalcemia, carpopedal spasm. And the second is the neuromuscular excitability. Neuromuscular excitability is seen in hypocalcemia, and in condition of hypercalcemia, when calcium is more, neuromuscular excitability will be decreased. So tetany manifestation can be there. So what is the workup for such patients? What is the workup? Workup means that what kind of tests or what sort of investigation we need to do in case of Gitelman syndrome. First of all is that we need to check the serum levels of sodium and serum levels of chloride. What do you think? And also potassium as well. The serum level of sodium as well as the chloride as well as the potassium will be decreased. Okay, because sodium and chloride is being lost into the urine, so serum level of sodium and chloride is decreased along with the potassium. But why is that so? Because due to the release of aldosterone, the potassium is being lost into the urine, right? So serum levels of potassium as well as the sodium and the chloride will be low. But you can say that there is compensatory aldosterone release, there is compensatory RAS mechanism, so there is reabsorption of salt and water. But does it not compensate with the pathologic process? No. We can say that the pathologic process, that is the Gitelman syndrome, will override the physiologic process, that is renin angiotensin aldosterone system. Okay. The second thing is that you need to check the urine osmolality. Urine osmolality. Urine osmolality will be decreased because polyuria, water is being lost. So due to less salts, although the salts are very much in high concentration in the urine, but water is also in high concentration. So urine osmolality will be decreased. The other thing you need to check is very important test, that is known as serum magnesium. That is like logical, right? Serum magnesium will be low. Hypomagnesemia will be there because magnesium is also being lost into the urine. The next important test in case of Gitelman syndrome is 24-hour urinary chloride. 24 hours urinary chloride. And what do you think, that 24-hour urinary chloride will be high or less? It will be high because the sodium and chloride is lost into the urine. So 24 hours urinary chloride is high. This test will show an increase in the urinary chloride over 24 hours. And serum magnesium, it's hypomagnesemia, urine osmolality is low due to water presence, and the serum sodium, calcium and potassium will be low. And one more important thing I want you to know, that the Gitelman syndrome is the mimic, is like manifestation, or you can see that it works like the chronic use of thiazides. There are drugs known as thiazide diuretics, right? And thiazide diuretics also block the sodium chloride co-transporter in the distal convoluted tubule. So it means that congenital tubulopathy, that is Gitelman syndrome, it works like if a person is having a chronic use of thiazide, but it is not involving thiazides, but the symptoms of the patient with the Gitelman syndrome are same as the patient who is suffering from chronic use of thiazide, or we can say thiazide toxicity. What are the drugs that are included in thiazide? We can say hydrochlorothiazide, Hydrochlorothiazide can be included in thiazide diuretics. And the second is chlorothalidone. Chlorothalidone, right? These two drugs are included in the thiazide diuretics, and these are antihypertensive drugs. They cause the water loss, they cause salt loss, so it is used to treat the hypertension of the patient. But in like discussing about Gitelman syndrome, they work as the Gitelman syndrome manifestations are same as the patient who is using thiazides chronically, right? So this was for today. I hope you understand the concept behind the Gitelman syndrome, and in the next lecture we're going to discuss about the Bartter syndrome. So thank you.